and care. Actually, the reality has to be that the responsibility has to fall on everyone. This presentation is meant to give you a comprehensive overview on how to engage patients and their families in dialysis facilities. You'll learn common barriers to engaging patients and their families in care, as well as strategies to overcome these challenges. And finally, the module will discuss the next steps you can take to implement and improve engagement and communication. Objectives that I just wanted to review with you, we're going to summarize the CDC collaborative and the core interventions in relation to patient education and engagement. We'll understand the relevant topics of patient education in the dialysis setting. We will illustrate the importance of patient and family involvement in a patient's care and treatment plan, and we'll discuss effective methods of patient engagement. I'd just like to share with you a short video that highlights the importance of patient engagement and the benefits of patient empowerment. This is Jay's story.
The audio is on the video. It might be a setting on your computer. I did see a couple people put that in the chat.
For all of you, I'd like to just start with the basics and review the CDC Collaborative as a means to introduce while emphasizing patient engagement and education. In 2009, the CDC, in partnership with the Maryland Department of Health and Mental Hygiene and the Mid-Atlantic Renal Coalition, established the Dialysis Bloodstream Infection Prevention Collaborative. Its goal is to prevent bloodstream infections and create a broader interest in infection prevention among the dialysis community. Participants from patient, both freestanding and hospital-based hemodialysis centers located across the country. Facilities measured bloodstream infections via NHSN's dialysis event surveillance, and created and implemented evidence-based practices to prevent infections and share ideas, successes, and barriers. Adopted the 9 core interventions for infection prevention. The core interventions include surveillance and feedback using NHSN, hand gene observations, catheter and vascular access care observations, staff education and competency, patient education and engagement, catheter reduction, oxidine for skin antisepsis, cat hub disinfection, and antimicrobial ointment use. These interventions have been proven to reduce bloodstream infections in dialysis patients, and interestingly enough, include number 5, which is the reason we're here today. So what is engagement? Patient engagement is the active involving patients and their families as active members in the planning, delivery, and evaluation of patient care. The ultimate goal for all of us is to engage patients and families to create conditions that let patients, family members, clinicians, and facility staff work together as partners to improve the quality and safety of care. Partnership is important because healthcare quality and safety directly affect patients and families. Patients and family members take part in changes and improvements by providing input from their point of view. It's available for the facilities to invite patients and family members to give feedback about their experiences and ways that could be improved. It's so important for us to remember that most people, there are more people than just the patient and the facility staff that impact the quality of patient care. These relationships are pretty visible to us in our dialysis facilities. For example, friends or family members who attend treatments with our patients. But there are other family members and caregivers who may never come to the facility, but they still hold a very important role in the patient's support, and we need to acknowledge these relationships if these people are interested in being involved in the patient's treatment. Family-centered care is the collaboration of healthcare workers with patients and families of all ages and all levels of care and in all healthcare settings. Members are defined by the patient, not by us, and they are essential to the patient's health and well-being. Something that we need to remember as we think about patient and family-centered care is dealing with dignity and respect. We need to keep the information pathways open in both directions, encouraging participation and collaboration with all members of the team. Engagement can offer many benefits. Certainly it's a patient right to understand and participate in their care and the planning and decision making. But engagement also leads to positive treatment outcomes. It fosters trust and improves the nurse-patient relationship. Engagement can be seen at the facility level by improved quality of care, increased patient safety, improved morale, and better patient outcomes. We are going to find barriers to successful engagement of our patients. 3 distinct barriers that I'd like to address today would be the barriers of variability, time, and ownership. The variability just speaks to the differences that we find among each one of our individual patients. They all have different expectations and levels of interest in engagement. Other areas of variability for patients might be in terms of their support structures. They may have different levels of understanding of medical information and health literacy. They may have different cognitive functioning and physical capacities. And we need to also keep in mind that there are varying levels of trust in the medical professionals and staff. The ability of time, I think, goes without saying. Engagement takes time, and it takes planning and patience. Fortunately, in a busy dialysis facility, time is at a premium. We need to understand what level of ownership a patient would like to take in terms of engaging in their care. We also need to develop strategies for effective engagement with our patients. We also need to coordinate engage tactics with our staff members. So none of this happens overnight. Ownership is another barrier. Sometimes it's unclear whose responsibility it is to engage the patients. Staff members are not sure. They think it's somebody else's responsibility. They assume that somebody else is kind of leading the engagement crusade, and that may not be the case. So we need to think about owns this process, who's going to participate, and we need to define lines for all involved. Working through these barriers is got to be a priority for each facility. Barriers are going to be, I think, individual to each facility depending on your patient population and your staff population. But it needs to be a priority to identify the obstacles that you face and come up with strategies to implement better engagement at each facility. It's good to focus on topics and strategies that are specific for what your needs are, include staff and patients, and obviously communication is really important. We need to engage. Part of patient engagement is being an engaged member of the patient's team. We need to listen to them. We need to share our own views, but understand that they have their own views. So there may be some disagreements along the way. Good communication skills are important. We need to ask questions. We need to encourage them to ask questions, and the basis of it all is respect. Some of the basic effective communication tools. We need to remember that we should be speaking slowly. We may need to repeat things a number of times before understanding happens. We should make eye contact, and we should make sure that we're at the patient level. If they're in their treatment chair, then we should pull up a chair or a stool so that we can be eye to eye with them. We should definitely use medical jargon, use plain language that they can understand. If at all possible, give them information that they can take home and review in a less stressful environment. We should invite patients to ask questions, and we should thank the patient or the family member who brings attention to any issue. In the strategies for effective patient education engagement, we need to make sure to educate and re-educate patients on key infection control techniques. For all patients, we need to educate and re-educate on hand hygiene and symptoms of infection, general access care at home, and what to do if there's a problem when they're not at the dialysis facility. Specifically, patients with catheters should know the risks associated with their catheters and the importance of obtaining more permanent access and get rid of those catheters. And they should know basic infection control practices during accessing and de-accessing of their catheter, as well as exit site care. And the patients with permanent vascular access, AV fistula or AV graft, should be washing their access prior to treatment, either with soap and water or with alcohol-based sanitizer. And they know the basic infection control practices during cannulation and decannulation processes. A way to remember the key elements of infection control education is the use of the acronym CHARGE. CHARGE stands for Culture of Safety, Hand Hygiene, Access Site Preparation and Cleansing, Reduce and Remove Catheters, Great Connection, Disconnection Technique, Evaluation of Team Infection Control Practices. These are things that staff and patients can take part in to reduce infections in dialysis. So the C, the culture of safety, is we want to create a culture where all patients, families, and staff members at all levels have open means of communication so that questions can be asked and everyone can speak up in a safe and comfortable environment without fear of retribution. For hand hygiene, we need to educate our patients on the 5 moments for hand hygiene. Ask patients to be your second set of eyes to acknowledge both successful and missed hand hygiene opportunities among staff and other patients. The A, access site. We need to teach our patients not only how to properly cleanse and care for their access site, but they need to know why they're doing it. And we also need to know to see a return demonstration to validate that their understanding. Our reduce and remove catheters. We educate patients on the fistula first and the risks associated with catheters. We ensure to involve patients in the decision-making process and the care planning of this transition. Connection and disconnection would be the G. whether it's a catheter or an AV fistula or graft, proper technique is key. With real-time feedback is the best way to maintain consistent care techniques across all care disciplines. The evaluation involves patients in the quality assurance and performance improvement process. By asking patients for feedback on how the facility and staff are doing, it empowers them to speak up, to ask questions, and to stay informed. Resources that we use in our facility are listed here. There's many good handouts and information tactics for education on the CDC website. I'm sure you're all very familiar with. I'd like to share with you what we're doing in our units to engage and educate toward the goal of best practices in infection control. We need to engage the key players, and by that I mean staff and patients and families and caregivers. In our units, we recognize that in order to get patients and families to buy in, we first had to drive home the importance of proper infection control to our staff. About 4 years ago, one of our clinics was cited at a conditional level for infection control practices by the Massachusetts Department of Public Health. This was an eye-opener for our staff who I think thought they pretty much had it under control. We went through a pretty vigorous re-education plan with return demonstrations. Some of our staff members got individual remedial education. We evaluated our policies and procedures, and we initiated ongoing practice audits to help staff to see that shortcuts can creep in and the negative effects that they can pose. Staff were kind of feeling a little bit put out. I think they felt that the layers of PPE, you know, the gown, the mask, the shield, the gloves, they looked at it more of as a form of punishment to have to don and remove it so many times throughout the day rather than as a protection for both them and the staff. So we focused on making them understand why it was being used and the importance of it. We also targeted proper hand washing techniques and specifically spelled out the 5 opportunities for hand washing so that they were better able to recognize and understand when opportunity presented itself. So once we started to make some headway with our staff, they started to see the importance of involving the patients and the families to really close the loop on infection control. So our hospital-based system, the health system utilizes crew resource management as a team approach to making sure that all voices are heard. So our council was formed through the crew tool. It is comprised of staff members who work to identify department issues that might need to be changed, and they work together toward mutually agreeable solutions. So the council started to take on patient engagement education tactics. Some of the ways that we started our patient engagement and education in infection control, we have a patient newsletter. Articles included the importance of washing and the proper techniques to prevent infection. Another article was on catheters and versus fistulas and grafts, and the high potential for infection in a catheter patient, as well as a higher mortality rate in patients with catheters. We worked at empowering our patients to participate in their own care rather than be passive recipients. We encourage patients to pay attention to what their caregiver is doing and question practices that they think might be unsafe or not according to the protocol. And we ask patients to remind staff if they see them without gloves or not washing their hands. We demonstrated with our patients the appropriate hand washing techniques. We identified patients who would be able to come in and use soap and water at a sink, others who might need hand sanitizer for a reason that they couldn't get to the sink. We then we had teams in the unit who took each group of patients and started education one-on-one with the patients with return demonstration to start to get these habits. Actually, it was a good way for both staff and patients to begin habit changing. We do have posters also from the CDC site, many of them hanging in our units, and we try very hard to rotate them through on a regular basis so that they don't become kind of a white noise type of thing. Then kind of employed some of our patients as advocates and ambassadors. Some of our patients will come in a little bit earlier. Some will stay a little bit after their treatments, trying to remind their other patients to wash their hands as they arrive or as they leave. Patients are also asking the staff, did you wash their hands? Kind of the same question that the staff are asking the patients. It goes both ways. We have some of our fistula patients talking to some of our catheter patients, encouraging them to make the switch for the best interest of their own health. We're finding is working in our units. The CDC audits, because with constant vigilance, shortcuts are going to creep in, and that means quality of care drops. We utilize the hygiene audits, the catheter connection and disconnection, and the cath site exit care, the AV fistula and graft cannulation and decannulation audits, as well as station disinfection audits. We will offer progress reports to patients and staff. We have a quality whiteboard, which is in view for patients and staff to be able to see, and we report out on daily, weekly, and monthly measures for improvement in our care. Some of the, for example, measures are, at this point, we're looking to make sure we're reviewing access visibility and the appropriateness or the accuracy of our data entry into our EMR, making sure that correct weights are entered. On a weekly basis, we report out on the audits that have been performed for that week, and on a monthly basis, we report out some of our QAPI information, our dialysis adequacy, any infection rates, our long-term catheter rates, et cetera. We've also strategically placed our hand sanitizers as to be able to best remind staff and patients to use them. They're on every machine. We've got the entrance and exits. Also are very fortunate to be in the process of building 2 brand new facilities as well as renovating our 3rd unit. So as part of our facility planning with these innovations, hand washing sinks were paramount for placement. In terms of our station disinfection, we hold off on any disinfection of each station until the patient has completely left. Previously, we used to strip down the machine, wash the machine while the patient was perhaps holding their sites, and then when they were ready to leave, then we would clean the chair. We now do the entire station and any equipment that was brought to the station once the patient has left. We also are pretty fortunate in our area. We have what is known as the Friends of Renal Dialysis, or the Ford Foundation, which is a nonprofit organization which was started by some of our former patients and family members to support dialysis-related endeavors. And the Ford Foundation not only offers a summer picnic and a holiday luncheon for our patients, but it also sponsors some lunch and learn opportunities, which is nice because it allows patients to socialize away from the dialysis unit at the same time learning about such topics as home therapy options, transplantation, diet and fluid management, access options, and infection prevention. Other thing, as part of our hospital-based units, if a staff member has declined the flu shot, it's a hospital policy that that staff member wears a mask while on duty throughout flu season. I think for my presentation today, I'm hoping that Dawn has been able to join us.
Thank you. I think we have her on the line. We just have to unmute her from my computer. But Thank you very much for your presentation. You did. I think it's beneficial. For the participants, we are gonna hold on the questions till the end after we hear from Dawn. So we move on to that second half of the webinar, and we're going to hear from a very inspiring patient, Dawn Edwards. We're very excited to have Dawn partner with us for this webinar, and hope her story is as inspiring to you as it was to us. Dawn has been an ESRD patient for 25 years and has received dialysis through every available renal replacement modality. She's volunteered with the ESRD network for 15 years and was employed with her network as a community outreach coordinator from 2006 to 2010. Member of the IPRO Board of Directors and participated in many network committees and activities. Passionate about infection control and is here to her story on how dialysis-acquired infections affected her and her family. Thank you so much for being with us today, Dawn. And I think I finally have you on the line, do we?
I hope so. Can you hear me?
We can.
Oh, thank goodness. Okay, fantastic.
Good. Ready to have you, so I'm going to hand the floor over to you, okay?
Okay, thank you very much.
Thank you.
It's really great to be asked. I want to thank everyone from the Connecticut Network for inviting me to be a part of the call. It certainly is a privilege as a patient to be invited to be a part of educating our staff members. One second. And I'm just going to go ahead and jump into the presentation. And I really hope that, together Kathy and I can help to make some changes or be able to stimulate you into being better concerned or even more knowledgeable about infection control. So just a little about myself. I've been a ESRD CKD patient for 25 years. I spent 3 years on in-center hemodialysis, and around that time, after the 3 years of in-center, I decided that I needed to feel more empowered about and more in control of my treatment. And so I transferred out, and I did PD for 9 years, and then I spent 6 years, thankfully, with a transplant, but transplant experience did not go well. Actually, it was pretty much of a disaster. And I came back to home hemodialysis, where I have spent the past 7 years doing home hemodialysis, and currently I'm doing nocturnal home hemodialysis. I always thought that infections were commonplace in dialysis from the things that I've learned in the waiting room, listening to patients. Everybody was talking about they had this infection or that infection, and I thought that it was a pretty simple process. You get an infection, you take some Vanco, the infection goes away. After some time, I learned that I was sorely mistaken having this thought. I quickly learned that infections and infection control is a matter of life and death. And just to give kudos to Kathy, education is so important, not just among the staff members, but the patients. The patients have to feel like they're a part of the care team to the best of their ability. Need to be involved. They need to know that this is a matter of life and death, and that it doesn't just happen to people who may not look like they have the best hygiene or people who are the sickest. It can happen to anyone, and it's something that the entire disciplinary staff needs to be involved in order to prevent these infections. So experience with infection is in 2011. I was on in-center hemodialysis for a brief time after a failed transplant, and I was not able to get a graft or a fistula after spending so many years on dialysis. Veins and everything was all used up. I didn't have a spot to place a graft or a fistula. So I was stuck with this catheter, which is, which made me feel bad because I had always learned that having a graft or a fistula, fistula first, graft second, catheter last. So I felt like, the dirty girl in the unit because I did not have the gold standard access. However, I was with this, with the catheter, and there was not much that I could do about that. From my transplant experience, I caught the early stages of colon cancer, so I did have to have my colon removed. I got bone disease from the anti-rejection medications as well, and I needed a hip replacement. My hip was completely fractured. And this particular treatment, I just had an overall bad feeling that day, and I noticed this weird little rash on my belly that I thought might have been the shingles. The dialysis treatment, I felt worse and worse. The nurse called an ambulance. I was headed off to the emergency room. The diagnosis was sepsis. And not only was it sepsis, but after some time and after some studies from infection control and infectious medications, just medicine, I was diagnosed with MRSA. Naturally, I was quarantined. Infectious disease had to get involved, and as a result, I was unconscious. Completely lost track of time. I was unconscious for weeks. I was resistant to the antibiotics. As a result, my family was absolutely devastated. My daughter was in her teenage years, and she began acting out because she was unsure of, the fate of mom. My mother and my sister were working overtime, working shifts, trying to make sure that I was being cared for appropriately in the hospital with this ostomy, and it was just terrible. Actually, my family was even to the point where they were told to start to discuss final arrangements just in case it didn't work out the way that they had hoped. Friends, church family, everyone was prepared for the worst. And even my staff members who I had known so well at the dialysis unit, they were waiting for daily reports to find out how I was doing at the hospital. Early, I began to make a comeback. I began to respond to medication. Of course, I lost an insurmountable amount of weight. As you can see in the picture, I'm not exactly the tiniest young woman, but just to give you an idea of how bad a shape I was in, weighed under 100 pounds when I got out of the hospital. Doctors and the nurses and staff, they found my recovery miraculous. Thankfully, I was transferred from the hospital to rehab so that I could get that hip taken care of. And I finally returned home in June of that year, and the was diagnosed in January. That just goes to show you how devastating that was to myself and my family. Everyone takes a part, and everyone can help in the prevention of these infections. And just like Kathy said, I couldn't agree more with the complete direction of her presentation, how she discussed having the family members involved, having the patients involved, the education. I mean, she had a complete, well-rounded approach to how we go about preventing infections. She talked about everyone being a part of what's going on, with our patients. And other staff members helping in education. We know that time is, of course, of the essence in dialysis. You have to get on the machine. You have to, take care of the monitoring of patients. You have to get them off. And sometimes, patients are very limited in their ability to understand. Or another thing that I've noticed from my personal experience, when I was sitting in the dialysis unit in the chair, I could not really comprehend a lot. I was more concerned about what was going on in the unit. I was looking around to see who was washing their hands and who wasn't, and looking around to see if other patients were doing okay. And I was consumed with what was going on around me. So I came over and did take a seat, and attempt to give me some education. I really wasn't in the place to comprehend all of that because there's a real serious medical treatment going on at the time. So that could also be a consideration when we're talking about educating patients. Like I said, there was the Ford Foundation at her hospital. I have an organization that I've begun here in the New York area where we are doing something similar. We are go around doing lobby days with patients, talking patients outside of the dialysis facility where they're more apt to listen and they're ready to absorb the knowledge that you're giving out to them. There's so many different ways that we can go about doing this education, and in my opinion, an educated patient is an empowered patient. And when a patient becomes empowered, they don't feel bad about asking a staff member, sorry, did you wash your hands, or would you mind going back and doing it again? I didn't see you, or please don't handle my machine without having a glove, having a glove on. That's all a part of the empowering process because, of course, we know that there's patients that sit there and go to sleep from the time that they sit down until the time that they get up. And you can't be responsible for what you can't pour into a patient, but giving them the education side of the dialysis chair sometimes makes a difference between life and death. So, we want to give patients as much information, education as we can from a variety of different people, from a variety of different resources. Again, teaching some patients that are a little bit more alert and able to retain information and having them have them educate, doing peer mentorships. That's a fantastic way. Sometimes patients have a tendency to feel that they can't trust the medical professionals, even though, yes, you are professionals. They don't feel that they can trust. However, they'll have a better relationship, or they'll be more apt to and follow what they hear from other patients. And that's why we have to be so careful about the education that we provide with patients, because there's good information and there's horrendous information. So, with being said, I think it is really important that we all take infection control and educating patients, educating one another as staff members, being vigilant in the unit, looking around at your own coworkers and, even not being ashamed to say or not feeling that they're not going to be friends with you if you say, you know what, you're not supposed to be here without your mask on, or that you're supposed to have your face covered, or I can see you wash your hands. It takes a village, and it's really a matter of life and death. And with that being said, I just want to thank you so very much for your time and your attention, and I hope that I've shared some good nuggets with you. And again, Kathy did a phenomenal job, and I hope that you really take into consideration all of the great information that she provided you. And thank you all very much.
Thank you so much, John. We really appreciate it. I know I speak for a lot of people when we're glad that, you did make it through all your hardships, and, we're lucky to have you with us here today. And you're an inspiration to a lot of people, and I know you work hard with a lot of other patients to, make sure the same things don't happen to other people. So we appreciate everything you do for the community and so I have you.
Thank you again.
So we open up the floor for questions. For both Kathy and John. So you can either unmute everyone or submit them through chat. I am going to unmute everybody, so if you're not asking a question, in order to avoid background noise, please mute yourself if you're not speaking. I'm having some more technical difficulties right now. I apologize. Are you able to see the chat? John, video?
Here.
Okay. I thought I saw you click off. Our chat window is suddenly unavailable just when we need everybody. We need to face chat window. So just bear with us for 1 second. A few things why I'm looking for this is we want to remind everybody to make sure you complete the survey when you edit the webinar in order to get your CNEs. Our next webinar is scheduled for May 9th, and we will be hearing from Sally Hess from the CDC. And we do chat available. So if anybody has any questions, enter it there. Everybody is unmuted. There's a lot of background noise. You can mute yourself. Okay, I have a question from Dr. Meltzer from Connecticut DPH on talk about how to overcome that. Are you able to hear me there?
Well, I'm not able to hear you.
Can you hear me, John?
Yes, I heard you.
Okay, so Dr. Richard Meltzer asked John to talk about how to overcome staff at so I think, when a patient is up against staff, how can the patient overcome that resistance?
I'm sorry, I'm having trouble hearing you.
Yeah, there's a background noise. I'm going to mute everybody. Have you. Okay, great. Is it better now, Don?
Hear you just fine. Can you hear me?
Yes. There's a
Great.
lot of background noise, so I apologize to everybody for some of the technical difficulties. But we do have a question from Dr. Richard Melcrit from the Connecticut DPH for you, John. And he asked, could Don talk about how to overcome resistance from staff when a patient advocates for her or himself?
let's see. Well, I think that it's fantastic if a sorry, did he ask if a staff member advocates for a patient?
I think asking
Oh,
if you feel when you feel resistance from staff, when a patient is to say
yes.
stop against a staff member, how can you overcome some of the resistance from the
Oh, goodness.
facility?
That is absolutely the worst possible case scenario. I know plenty of patients that are afraid of speaking up in the facility because of that very thing. They're afraid of retaliation. And the only thing that I can say is empower, educate, empower, educate, empower. I know that we have our HIPAA violations, but we do some facilities have patient representatives that maybe could go and speak to fellow patients and then talk about it in an open forum and in terms of a facility meeting on alternate days where everybody can sit around together and say, well, whoever I just say this, but I used to call myself the big mouth in the unit. Whoever the big mouth in the unit is, you can just, come out and say, well, listen, we are very concerned about infection control. And there have been, numerous incidents that have been referred to me, reference to staff members not washing their hands. It's very, very difficult for a patient that might be introverted or might be afraid. Anything could be happening. So my advice would be to maybe try an open forum or talk to patient representatives and allow them to speak to patients and allow them to refer back to staff members, the appropriate staff members, not everybody in the unit, but the appropriate staff members.
Great. Thank you, Dawn. That answered your question, Rich. If anybody else has any questions, again, feel free to submit it in the chat. It looks like there aren't too many questions coming through right now. Keep the webinar open for the next 10 minutes if anyone does have a question. But while we have everyone on the line, I do want to, again, thank both Kathy and Dawn for both your time here today and in preparing for this and for all you do, for your patients and your peers. We really appreciate it. And thank you for being a part of this webinar today.
Okay. Thank you very much, and you're welcome as well.
Thank you. We're dropping off at the end of the call, so we're pretty much wrapping up. If people do submit questions after, I can email Kathy and Dawn as well in case we get anything after the fact. I know this webinar we only had about a week notice, and we usually go about a month just because of everyone might be a little more today than normal. Thank you to all coming. We're just going to keep it open, but if you don't have any questions, just drop off. As long as you complete that survey at the end, we will be sending yours. Okay. But thank you for coming today, and special thank you to Dawn and Kathy.
I could hold on for just 1 second. Someone's asking me a question. Asking me if I would be willing to join them at a clinic level to share my story. Answered absolutely. So
I believe Susan Richmond asking that question to John. John, if you're happy to do that, I can email her your email, and then you guys can be in that way if you would like me to do that for you.
That'll be fantastic.
Okay. Thank you, Susan. Kathy and John, looks like everyone's slowly dropping off, so I think they're taking the survey. So I'm going to end the webinar. I'm not going to hold you guys any longer for questions. I would think they would have popped up by now, but I will email you if someone does anything after the fact or sends us any email. I will pass along any information. Okay.
So wonderful to meet you.
It's wonderful to meet you too.
Thank you. Take care.
That's so funny. Everyone says that I'm long-winded. I could have talked for another 10 minutes.
You did a great job.
Thank you. Okay, you guys have a great day. Thank you.
You too.
Bye-bye.